Clinical history. Well, setting up the risk factors would be exactly as to what we talked about earlier with coronary arterial disease, and we'll look into that in a little bit. Non-invasive testing. Okay, so now this would be the first time in which we're not using EKG, obviously here. Makes no sense. We're not in the heart. We're down in the periphery, okay? So what kind of non-invasive test? How important is this? Really important. Because the more that you are able to come up with non-invasive testing and it being efficient and effective, the better off you'll be in every possible way. You'll be respected by your peers, and in terms of next step of management, any questions that you get, here it is. It's called ankle brachial index, and that's the one that we'll pay attention to. Now, there are a couple others that you may do as well, but at least get this one down. Once you have understood ABI, ankle / brachial / index, in other words, you're going to measure the pressure in the ankle. You're going to measure the pressure in the brachial upper extremity. Are you there? And you're going to do a ratio. When you do that ratio, you'll get a particular number, and this is what I'd like for you to understand. You can sit there and memorize all this stuff, but why would you want to do that? Because in the long run, it's really not going to help you. Because it's just too much to memorize. Really, just too much to memorize, isn't it? So what I'd like for you to do is think about, well, what exactly is happening with the pressures in the two extremities? And what can you expect with the ratio? And once you do that, you'll be much better off. And we will, ladies and gentlemen, we'll be doing this, and we have been doing this for every single organ system, from like BUN creatinine ratio to tubular fluid to plasma ratio, nephrology. I mean, you name it. Every type of ratio that we've done has been the fact that it's all about understanding and what you can expect normally, so that you can then identify the abnormal. So take a look at this. So we're going to do either right or left, and we'll put both up here. And ankle A, then brachial. Do alphabetical order. The ankle will be on top. This is ratio, the math. The ankle will be on top, A. The B, brachial will be in the denominator, as you see here. Okay? So that would mean ankle, and then you have your brachial, the arm. Once you get the ratio, now you tell me, where do you expect there to be a higher ratio? Where do you expect there to be higher pressure? In the ankle or the brachial? Take your time. Ankle. So, when we do a ratio a little bit, we're going to find where you can have your upper normal limit of that ratio being above 1. So, if you're suspecting, now let's jump ahead. You ready? Why we're doing this? Ask yourself that question. We're going into technicality and details, but why? Why are we doing this? Because we're trying to identify non-invasively whether or not your patient is suffering from peripheral arterial disease. Okay, now use common sense now. If there's peripheral arterial disease, am I supplying adequate amounts of blood down to the dorsalis pedis? Of course not. So what would you expect that pulse and the pressure to be? Decreased. Are we clear? Let's move on, and let's confirm this. You measure your ABI. Interpretation of it. Abnormal absent pedal pulses. I can't feel it. Age greater than 20. And you find that your patient has a history of smoking and diabetes mellitus. Wow. Let's go ahead and confirm this non-invasively. You find your ABI, ankle brachial index, to be less than 0.9. Please know that you have confirmed diagnostic of peripheral arterial disease. This is the one that you pay attention to first and foremost, please. Now, as I fill in the gaps a little bit more, well, this would be good information for you to keep in mind. I'll give you normal and what that means when you have excess. For right now, let's just keep at task. And our task at hand is to confirm non-invasively peripheral arterial disease. We're using ABI, ankle brachial index. And so therefore, we said, and you agreed, that the ankle pressure should be higher than the brachial. And if you find with peripheral arterial disease that the ankle pressure is quite low, then what can you expect that ratio to be? Work with the concept first. A low ratio, right? Once you find a low ratio, what have you done? You confirmed PAD. What exactly is that number? Less than 0.9. Then you memorize the number. You do that every single time. Well, the fraction excretion of sodium later on in nephrology. You understand the concept first, and then you memorize the numbers, if you must. But the concept will never leave you. do another one. This is normal, between 0.9 and you can go all the way up to 1.3. The ankle pressure is a little bit higher. So therefore, this is normal. No further testing is required. What if you find your ankle to brachial index to be greater than 1.3? Then your next step of management is your Doppler. So now you start thinking about ultrasound and such, a duplex Doppler. There's something else called a toe pressure. Just keep these in mind as your next step of management if you find your ABI to be greater than 1.3. Less than, take a look, with confirmed PAD. Now, if it is greater than 1.3 and you found this to be confirmed with a Doppler waveform, then you start thinking about diabetes mellitus, and even end-stage renal disease may have falsely elevated levels. Renal failure in nephrology, we've talked about quite a bit with end-stage renal disease. And there, oftentimes, you find your blood pressure to be quite high, don't you? Right? Why? Because you don't have proper GFR. So if your GFR drops, then you're going to build up more volume. Welcome to hypertension. So you might have falsely elevated levels with ESRD, end-stage renal disease. At this point, your focus should be peripheral arterial disease and how we confirm that by having a low ratio. Let us move on. The modifiable risk factors, these are the same ones that we saw earlier with any type of atherosclerotic disease. These include, if you can, try to implement smoking cessation programs, blood glucose level for diabetes, the treatment of dyslipidemia, statins. What was the other one with the statin, which is now, current day practice, proven to be incredibly effective, called a proprotein convertase, PC, subtilisin S Kexin 9 inhibitor. And those are your either alirocumab or evolocumab. Available now and decreases your LDL cholesterol up to 70%. Treatment of hypertension. All of these are modifiable risk factors. Modified risk factors include also antiplatelet therapy. See as to whether or not you can get in there and bust that clot. Aspirin. Have their obstructed lesions bypassed surgically if need be. Worst case scenario, talked about that diabetic who has peripheral arterial disease and diabetic neuropathy, and there's enough necrosis and gangrene that in which the only step of management next is to then conduct amputation. And that's just unfortunate.